you hear
This
me?
conference will now be recorded.
Yes, sir.
Okay. So we'll start today with the last in the series of lecture on stomach, and this will be about the gastric neoplasia. Okay. So everybody is requested to kindly switch off their mics, and we're starting the lecture on gastric neoplasia. And to start with, certain benign conditions which are concerned or rather would be related directly or indirectly to the genesis of malignancy in the stomach. And you have those gastric polyps, the metaplastic polyp associated with Helicobacter pylori. They regress with treatment. That's very important. You can have the inflammatory polyps. You have the fundic polyps, which are associated with prolonged usage of the PPI. Yesterday, I was pointing it out to you that you can't use them indefinitely. And familial polyposis. You have the true adenomas. 10% of all polyps are true adenomas, and they've got a malignant potential, again, of about 10 to 20% chance, right? And then you got the gastric carcinoids arising from the enterochromaffin-like cells, and they are associated with pernicious anemia. But coming straight away to the malignancy, let's look at the epidemiology of the malignancy. You've got the geographical distribution in front of you, and there's the highest in Costa Rica, Japan, and China. And India is more in the southern part of the country as compared to the northern part of the country. The blacks are more affected than whites, and the male-female ratio is in favor of the male ratio. They got more incidence. The increasing age is again an important factor. You find most of these malignancies post 50 years, and the distal gastric carcinoma, which we were taught when we were studying, almost accounted for 60% of the malignancies of the antrum, and now it's shifted. It's almost reversed now. And there's another reason for the reverse. The other reason for the reverse is that now they are including the malignancies at the distal part of the esophagus and the esophageal malignancies in gastric malignancies. So that has also helped in changing the ratio more towards in favor to the proximal part of the stomach. But even otherwise, the distal gastric cancer, if you look, they are decreasing at about 1% per year. There's an actual decrease in this incidence, and the proximal is increasing by the same ratio, especially the esophagogastric junction. And overall, it's more in the lower socioeconomic status. We look at this small sketch, you'll find that the proximal is increasing in the higher socioeconomic status, and it's more of the diffuse type as compared to the distal part of the pyloric part, which you find decreasing at the rate of 1% per year, and is more common in the lower socioeconomic status group, and increasing association with Helicobacter pylori. And then you've got the pathogenesis. It's a multi-step process of growth, and you have the inherited acquired genetic component as one of the features in cellular substrate, acted upon by a variety of insults over a period of time, or you can have the pre-malignant lesions apart from genetic or inherited components, and they result in genetic mutation manifesting phenotypically as precancerous lesions. And so you have the same step as you find in the malignancy of the colon, starting from superficial gastritis to atrophic, and then leads to small intestinal metaplasia. That means you find this epithelium or endothelium of the small bowel, or rather replacing the mucosa of the stomach. You have the colonic metaplasia. It looks like the colonic colonic vessel, the epithelium, and you got the dysplasia and the final development of carcinoma. Then you got some risk factors, which I would just like to point out. You must be knowing all about these risk factors, but nutrition is one of them. And a low fat or protein consumption is they all in favor of generation of malignancy. Salted meat or fish, salt atrophic gastritis, it leads to atrophic gastritis. That's why a lot of salt is never beneficial for anybody. Of course, along with this, got a lot of other harmful effects. That's besides the point. Co-carcinogens in the form of preservatives, which contain nitrates or nitrites, they convert to the carcinogen, that's nitrosamine. High complex carbon or decrease antioxidants in the diet, which prevent the conversion of nitrites. If the antioxidants were there, they would have prevented the conversion of nitrites. So if you have less of antioxidant, that is in favor of generating malignancy. And that is a scenario where you usually find when you are taking less of fresh fruits, where there's a decrease in vitamin C, or taking less of green vegetables, which decreases your beta carotene intake. and both are, if you have them in adequate amount, they both are preventive antioxidants, right? So take a lot of fresh fruits and less of green vegetables. Environmental factor in the form of poor food preparation, like for example smoked and salted, lack of refrigeration, poor drinking water, especially well water, which is increased concentration of nitrates and helicobacter. Then smoking, industrial dust ingestion is again an important factor, but you find less and less of this factor because of improvement in the industries, the crystalline silica, the leaded gasoline, grain dust, lead dust, ink dust, hydraulic fluids, and dust of all kinds, even glycol ethers. Socially, as said earlier, low social economic, especially for the distal, and proximal is the higher economic status. Medical factors are also important. Like for example, if you had a prior gastric surgery, yesterday was pointing it out in peptic ulcer surgery, 2 to 6 times more susceptibility, and that also after 10 to 15 years after partial gastrectomy, even after gastrogenostomy and pyloroplasty. In all, what is working in against the stomach is the reflux, and that sets up the chronic gastritis, and that again sets up the whole chain in motion for in the end generating gastric carcinoma. Helicobacter infection up to 60% risk. There's a high risk, and it is responsible both for the diffuse and intestinal type of gastric cancer, more related to distal cancers rather than related to proximal cancer, as was shown in the first sketch on the first slide. Gastric atrophy and gastritis, both type A and type B. Again, yesterday I pointed out these were the old names. The new names would be autoimmune type or the helicobacter type of gastritis. Adenomatous polyp, 10 to 20% chances. I showed you in the first slide, and more than 2 centimeters size, including Menterius disease. And male gender, blood group A, 1.2 times risk, pernicious anemia. They're all risk factors for generating a gastric malignancy. But then coming to the genetic factor, which are now being increasingly recognized, one of them is autosomal dominant and DNA aneuploidy. You find 60 to 75% of patients with inherited gastric cancer. It's not all cancer, but inherited gastric cancer. Then you got the microsatellite instability, almost 25 to 40%. The term may seem to be a bombastic term, but it doesn't mean much, especially it's error in the DNA replication of the chromosome, right? And seen both in intestinal and diffuse type. That's microsatellite. Microsatellite is basically a DNA fragment in your chromosome. So they keep on replicating. So there's an error in the DNA replication. And it's been seen even in inherited cancer syndromes like the colonic cancer or Lynch syndrome, and also an acquired mutation. Inactivation of the tumor suppressor gene, the most famous being P53, and found in 70% of patients with gastric cancer, both of intestinal and diffuse type. So basically what you have to understand is that it's both the intestinal and diffuse type that has got all these genetic alterations. Amplification of COX-2 genes seen in 70%. These are quite high percentages for inherited cancers. Mutations of the APC gene, which is primarily responsible for the colonic cancer, 50% you find the incidence. Beta carotene and associated gene, 30% of patient intestinal cancer. E-cadherin, again gene in 50% diffuse cancers. Then you have a loss of heterozygosity at the BEL2 gene, which is an inhibitor of apoptosis, because you know apoptosis is responsible for killing the fragments which have been partially destroyed. So if you don't kill them, they ultimately lead to generation of malignancy. So those destroyed fragments have to be removed. So apoptosis is basically concerned with that. Overexpression, amplification of several growth factors, among them the all being innovated out here. You have the TGF, the epithelial growth factor, and so on and so forth, right? If you look at the hereditary gastric cancers as a whole, 10% of all gastric cancers are familial, and 3% are inherited cancer syndrome. And I've been repeatedly pointing out to you the difference between an inherited and a familial. Familial basically has to do with the environmental factors, more running in families, more because of environmental factors. It may or may not be having some kind of a genetic alteration, but inherited cancer syndrome would always have a genetic alteration. And hereditary diffuse gastric cancer, HDGC syndrome, is an example of that, usually manifesting at a younger age group. I just now said we said that more than 50 years is the usual age group, but here we find it in 38 years of age, associated with the premenopausal breast cancer. And you find a lot of conditions, malignant conditions, where you can find an associated gastric cancer. For example, Lynch syndrome, the familial adenomatous polyposis, Surzeger, juvenile polyposis, and so on and so forth. Even hereditary breast cancer and ovarian cancer syndrome, you find association of the gastric cancer. If we look at the survival figures of carcinoma of stomach, 5-year survival figures, Look, right from 1A, stage 1A, which has got 71%, to stage 4, 4%. But if you look at the overall survival figures, roughly in the region of 25 to 30%, right? Now, the other way of looking at the survival figures is, apart from the fact the overall survival just now said around about 30% an average, when the patient comes to you for the first time, 65% of these patients have advanced disease, basically meaning what? T3 and T4 disease. And 85% of these patients come to you for the first time would be having nodal disease. So that basically tells you one thing, and that is that the patient comes late to the for medical attention. 65% is basically a high percentage with advanced disease, and even 85% nodal disease is quite a high percentage. And the median survival in these persons who come to you, if they undergo curative gastrectomy, is 24 months only. Why survival, remember, 20-30%. With palliative therapy, you're not able to do anything. So palliation, then the survival is only 8 months. And without any treatment, it's only 5 to 4 months since the time patient has come to you. So only from the time the medical attention has been given to the patient or the diagnosis has been made for the first time, right? So worst time you diagnose, from that time you calculate these figures. Okay. Okay. So coming to the pre-malignant lesions, and there are certain pre-malignant lesions which have been identified. One of them is the polyps, the hyperplastic polyp, more than 2 centimeter size, and adenomatous polyp, even a 1 centimeter should be investigated. Remember the last slide we said 2 centimeters or more. But here, even with 1 centimeter, it should be investigated. And why? Because in patient-associated FAP, 50% of gastric adenomas are found, and there's 10% chance of gastric cancer. So remember, even a polyp, if you do a OGD and you find a polyp less than 1 centimeter or around 1 centimeter, it should always be sent for biopsy. Chronic gastritis, atrophic gastritis, dysplasia, metaplasia. Yesterday we showed the whole genesis of malignancy when we're talking about Helicobacter. Intestinal metaplasia, understandable, gastric ulcer. All are malignant unless proved otherwise. The dictum is simple. The dictum is simple. No gastric ulcer is benign unless proved otherwise. And that's ultimately works in favor of a malignancy to the extent that you can easily diagnose these patients. If you consider everything malignant, you taking an early biopsy. An early biopsy basically will mean what? Early diagnosis. So consider every gastric ulcer malignant unless a biopsy says it is not. Okay. Now ulcer in a gastric remnant, 10 years after prior surgery, if you have gastric ulcer remnant, 10 years after surgery, prior surgery, you'll find this patient to be turning into malignancy. Menetrier disease, 5 to 10% chances of cancer. Enterochromaffin-like cells, hyperplasia, again a pre-malignant lesion. It's usually diffuse, poorly differentiated neuroendocrine cancer of the stomach. Okay. Now pathology. Let's look at the pathology of gastric cancer. Adenocarcinoma, 95% of all malignant gastric neoplasias. That basically leaves 5% for other histological types, and these 5% other histological types, they consist of number one, squamous cell carcinomas, adenoacanthomas, carcinoid tumors, gastrointestinal stromal tumor, the gist that we know of, and the lymphomas. As I said earlier, it does not have any lymphoid tissue, but still you find lymphomas in the gastric area. The site and macro types. If you look at the site, I said earlier, 60% used to account for the pyloric malignancy. It's no longer so. It's 60% at the GE junction. And there's a shift from the pyloric to the proximal stomach. It's an absolute flip-flop. It was 60% here, 40 here, now it is a flip-flop. It's almost what? 20% here and 60% considering the GE junction. And that's basically the parts, and you can just remember the two. Macro types are superficially spreading, ulcerative, polypoid, serous. We'll talk about these macro types when we talk about the Vorman's classification later on. But young patients, usually young patients, they have a diffuse infiltrating type. And lanitis is also common in young age group. They're usually large malignancies, aggressive, and poorly differentiated, right? That's if you find malignancy in the younger age group, be sure that some of these characters will be present in that malignancy. So how do you define the gastroesophageal junction? That's very important. We talk about gastroesophageal junction malignancies to be considered along with stomach cancer or to be considered along with esophageal cancer. Now that is the problem. We consider them as esophageal or we consider them as a stomach cancer. Now for that we have to understand what the GE junction means. Now, if you look at the definition of GE junction has been variously defined as the upper limit of the gastric fold. Now see these gastric folds. So the upper limit of the gastric folds, lower limit of the palisade, and longitudinal vessels which are palisading from down. So either the lower level and the upper level. This is basically the columnar line esophagus. Now, columnar line comes from where? It basically is coming from the stomach. So the Z line is probably one method of saying this is a G junction, may not be right. But if you're looking from the OGD area, you're doing an OGD from the inside of the stomach, the Z line would be an area which could be considered as a starting point for deciding what the G junction is all about. Why? Because the distance between the Z line and the G junction is about 3 to 11 millimeters. So that means you take the Z line and from here calculate about 3 to 11 millimeters, and there you'll find the gastroesophageal junction. See, this is the G. So in other words, this is basically defined as based on the muscle. I'll just tell you what the muscle basically means. But one thing you remember here, the squamous mucosa of the esophagus and columnar mucosa of the stomach meet at this point. So this is basically a small area where there's a meeting point, but the actual junction is not there. So how do you define the G junction? It is basically a junction between the tubular esophagus and cardia, or the distal end of the lower esophageal sphincter, which is probably a better definition to define what is the G junction. So either you can define based on the mucosa, which is not a very good definition. Why? Because I just now showed you that if you look at the mucosa, the columns here and the folds out here, there is an area. There is an area out here which has got columnar epithelium nonetheless, but is part of the esophagus, right? So if you consider the G junction at this point, then the esophagus is having both the squamous and the lower columnar epithelium. Is that clear? So that is both parts of esophagus if you consider this to be the G junction. So a better method of trying to classify G junction is a junction between the tubular esophagus and cardia, which is basically defined as the distal end of the lower esophageal sphincter, right? But it's not a mucosal junction. So the definition based on a OGD is not the correct definition. Basically, a definition based on the finding of the muscle fibers of the lower esophageal sphincter. It is an intrinsically high pressure zone. Remember, it's a high pressure zone. Why? Because the esophagus needs to be closed at all times. Otherwise, you'll be having what? GERD, gastroesophageal reflux disease. So that is basically an area which needs to be closed at all times. That's why it's a intrinsically high pressure zone. And the Japanese Gastric Association defined the CCJ. This was the definition most recent, December 2018. And you have to remember the definition. Why? Because that is what is being followed in defining the malignancies for TNM classification, so on and so forth. So this is basically defined as a border between the esophageal and gastric muscles. See, it is again muscles to be defined from the distal end of the longitudinal palisading vessel, the lower esophagus, to the proximal end of the longitudinal gastric fold. So basically what we're looking at is the longitudinal folds. So these are the longitudinal folds. So this is basically the end of the proximal end of the longitudinal folds. So this is basically the part that is defining the gastroesophageal junction. And the priority of EGJ definition was the distal end of the longitudinal palisading vessel by the endoscopic finding. So in an endoscopic finding, if you want to define by the endoscopic finding, you have to go further than the lower end of the esophagus mucosa beyond the Z line, and about 3 to 11 millimeters beyond the Z line is the G junction. Is that clear now? Now let's talk about the cancer per se, and you got the cancer divided into two groups: one, the early gastric cancer and advanced gastric cancer. This definition holds true for every textbook you read, and that's the junction which is accepted by everybody, right? Now, the early gastric cancer, the definition to remember is that it's a T1-NEN. In other words, mucosal or submucosal growth with or without lymph nodes. Very simple definition, and a definition which needs to be remembered, right? Mucosal or submucosal growth with or without lymph node. That basically tells you that the early gastric cancer, when you're defining early gastric cancer, you're not worried about the end stage. But is that really true? Another part of the early gastric cancer to be remembered is that the size of tumors should always be taken into account, which is now being the new understanding. So apart from the fact that you have mucosal, submucosal growth with or without lymph nodes, you also have the size of the growth as the involvement for lesions larger than 2 centimeters should be the cutoff point, right? Why? Because the moment you have more than 2 centimeter size, you have an increased risk of lymph node involvement. Okay, now when you increase this lymph node involvement, that basically changes it may not change the definition. Why? Because we already said NEN, but it does change what the prognostication and basically the therapeutics of the disease in that particular age group, right? So approximately 10% of early gastric cancer, they have lymph node positivity. Okay, so that basically means what? The 90% of ECG may not be having any lymph node, but a group of early gastric cancers would be having 10% of these would be having a positive lymph node, and 30% would be having poorly differentiated malignancy. So that is important. I'll just take a minute. Sorry for that. I just wanted to switch on the fan. Okay, so 10% of the early gastric cancers have lymph node positivity and 30% are poorly differentiated malignancy. Now, early gastric cancer, is it a distinct biological entity? That remains to be controversial. We still don't know whether it is a different biological entity or it's just a part of an early pathology which is going on to the advanced gastric cancer. And based on this early gastric cancer definition, you can easily divide them into the mucosal involvement or one which has gone into the submucosal, right? So intramucosal or submucosal invasive adenocarcinoma is the further subdivision of early gastric cancer, right? And they have been macroscopically classified by the classification we know as a Ming classification. Remember, Ming classification is only for early gastric cancer. It is not for the advanced gastric cancer, mistake often made. So that is basically a Ming classification is only for early gastric cancer. It's a macroscopic classification, and it basically defines the growth as either protuberant, flat, or excavating. Now, I'll just show you what that means. This is the Ming classification, right? That basically divides it into 4 types, which we subdivided into 5, right? So type 1 is the protruding type, very easy to remember. 2A, 2B, 2C are basically the excavating type or the early excavation, the superficial, the flat, and the depressed. And type 3 is the fully excavated. That means it is going below the surface. So here it is above the surface. These two are at surface, par with the surface. This is slightly depressed, and this is excavated, right? So that is basically on the pattern of the lesion, the macroscopic lesion. And that is basically the expanding growth pattern, 67%, which is type 1 and 2A, because these two are slightly raised. This is flat. And the infiltrating, from here starts the infiltrating type. So that is 33%, right? But coming back to the slide that I missed on. So the early gastric cancer. What else do we know about the early gastric cancer? What do we have to know? The limited extent of the disease. We know it's limited extent, but also early stage of the development. That's what I was just saying. Is it a different biological entity, or is it just an early stage in the development of a subsequent advanced gastric cancer? Until the time we define as as a early gastric cancer, it is less aggressive, has an excellent prognosis, almost 90% prognosis, right? If the lesion is completely removed. But nowadays, ECG represents approximately what? 20% of all newly diagnosed cancer in the Western country. That means because we are becoming more aware of gastric cancer, even the slightest, and we have got the investigation of OGDs done more frequently for any kind of dyspepsia. So we're doing it more frequently. If we're doing it more frequently, the chance of identifying it earlier is very much there. So 20% of the newly diagnosed gastric cancer in the Western world is early gastric cancer. Compare this with the Japanese population and the Northeastern Asia, Japanese and Korean. They diagnose the early gastric cancer to the tune of 50 to 65%. Why? Because they got a surveillance screen. They got a scheme where they do an OGD in a wide group of patients. They are doing it basically just as a routine method of investigation. Why? Because they want to diagnose cancer earlier. So 50, 65% and 20%, almost 3 times. So they tend to diagnose their malignancy, gastric malignancy earlier than we do. And that's why their results are much better. Now, can it progress to advanced gastric cancer, which I was just pointing out? Yes, it can progress to advanced gastric cancer, and the average time is about 3.7 years. But it can progress even earlier within 1 year. So remember, early gastric cancer ultimately would be converting itself into a advanced gastric cancer. But during the time it is early gastric cancer, is it different biologically? We don't know. So what seems to be true is that at the time it is called early gastric cancer, it's probably the same disease spectrum which has got the early stage and then the advanced stage. So there's nothing different biologically, right? But until it is early gastric cancer, it's got an excellent prognosis. The 5-year survival rate is 90%. See that. What is the average 5-year survival rate for the gastric cancer? Almost 30%, 25, 35%, 30% average. Here it's 90%, almost 3 times. The recurrence rate is 1.9% of the cases you have a successful therapy. and the recurrence occurs within 4 months to 10 years post resection, right? So it can occur as late as 10 years and as early as 4 months, as early as that. So important risk factors for recurrence. Why does it recur? One, usually the submucosal invasion is more fraught with the danger of having an early recurrence. And nodal metastasis, which was there in 10%, and undifferentiated histology, which was there in 30%. These are the patients who are more prone to have early recurrence. Okay. Now, the early gastric cancer, the median age is 63 years. We are still with the early gastric cancer. Remember, advanced will be coming to subsequent. So median age is 63%. You can have anywhere between 21. See the early age to 21 to 89 years. Men again affected more than women, and the ratio is somewhere 1.4, 2.4 versus 1. So it's almost twice or 1.5 times as common as in the females. And the majority of patients with early gastric cancer, they are asymptomatic. Understandable. They only got a mucosal lesion, small mucosal lesion, not a very large lesion. They does not bleed. Even if it does bleed, it shows an occult blood in the stool. You don't have metamesis with that. So it keeps on developing until it is diagnosed finally with an OGD or whatever method you diagnose it with. The suspicions are raised, only then you start diagnosing. Now, 40% of these may present with some symptoms. So asymptomatic 60%, 40% with some symptoms in the form of non-specific upper abdominal symptoms such as heartburn, epigastric pain, so-called dyspeptic symptoms. This is a very, very commonly used term, dyspepsia, which really doesn't mean anything. It means a lot of things and may not mean anything. You say, I've got dyspepsia, it can mean anything. You can have bloating of the stomach, you can have burning of the stomach, you can have having regurgitation of food, whatever. So dyspepsia here in terms of what? Heartburn or epigastric pain, right? Typically heals with PPI. You give this patient PPI, the symptoms disappear. But that doesn't mean your malignancy has disappeared. But for a time when you have early gastric cancer, you're treating this patient with PPI, you would feel the patient feels all right, and you feel, yes, my drug is benefiting the patient. But then what happens? After a particular time, the patient has a recurrence of symptoms, probably because of re-ulceration or because of the subsidence of the symptom is no longer there, and the patient has generation of symptoms again. And at that time, once you find that your PPI no longer making a difference, at that time it's very important that immediately rush with endoscopy, and if you find a lesion, do an immediate biopsy. 10 biopsies to be taken, remember, minimum, and that is very essential. We just talked about the mean classification, so we'll go. Now, what is the management of early gastric cancer? See, we are concerned with one group of malignancy. So don't confuse with advanced gastric cancer. This is all early gastric cancer. That's why I written what? T1 and 0. I'll just show you what T1 basically means. T1 is basically a lesion which is T1A or T1B, which is basically what? Mucosa and submucosa. Okay, T1 is mucosa plus submucosa. It includes the submuscularized mucosa, of course. Mucosa, muscularized mucosa, and then you got the submucosa. That is T1 lesion. And see what's written out here? N0. When does N come into play? 10% of early gastric cancer. I repeat, point this out. But if you are fortunate enough, the patient is fortunate enough that his lesion has been diagnosed at the stage of T1 N0. Very clear, T1 N0. Only then he can be managed endoscopically by two forms. Number one, endoscopic mucosal resection or endoscopic mucosal dissection, submucosal dissection for deeper submucosal growth. So this is the endoscopic mucosal resection, EMR, and this is ESD, that is submucosal dissection. Okay, very clear. And there are specific Japanese guidelines because they're the one who are doing it maximum. And the Japanese guidelines basically say what? Number for curative EMR. See, curative EMR. The invasion is clinically confined to the mucosa. No submucosal invasion. Tumor size 2 centimeters smaller. Histologically differentiated. And no ulcer or ulcer scar in the lesion. That basically means that there has been no prior excision. If there has been prior excision, it's a recurrence, no longer EMR. It has to go on for a gastrectomy. Whichever type of gastrectomy you decide on to be done on that patient. Some form of gastrectomy has to be done. So T1 and 0. We clear? Can be done by endoscopy. Can. Why? Because even T1 and 0 can be tackled by gastrectomy. Whichever one you want. We'll come to gastrectomy later on. So T1 and 0, you got a preference or you got a choice. I wouldn't say a choice. A choice of managing these patients endoscopically. If it is only mucosal, that is T1A. T1A, remember T1A mucosal. If it's mucosal involving what? The mucosa and submuscularis mucosa, then in these patients you can do a EMR, that's endoscopic mucosal resection. If by chance it becomes T1B, which basically means submucosa also, then you could do endoscopic submucosal dissection for deeper submucosal without lymph nodes. Remember, N0. For all other T1 lesions with any N1, with any positivity, N1, N2, N3, whatever, you have to go in for some form of gastric. So is that clear? Early gastric cancer basically means T1A and T1B. If it is N0, you can have a choice of endoscopy, a choice, not the, it should certainly be done by that method. No, then you have a choice. And if it is T1N, any positivity, it has to go to gastric. Very, very clear and nothing very difficult of remembering that. But now coming to the major group, why? Because that is the patient is not so fortunate to come to you with a early gastric cancer. If he is, he's very fortunate. The surgeon is very fortunate. Why? By and large, I showed you the figure in the last slide that more than 2/3 of these patients, even more, in a setup like ours, in a tertiary sorry, I would say a secondary center, because tertiary they get uh, patients from everywhere. So the secondary center, they would be having advanced gastric cancer more than what, 70-80%, more than that. So if you look at the classification for the advanced gastric cancer, see advanced gastric cancer, and what class we are talking about? Macroscopic. So macroscopic advanced gastric cancer, the classification is the Borman's classification, and that is the most commonly used classification method for advanced gastric cancer. And based on what? Number one, the appearance, and number two, the growth state of the tumor, right? And it gives satisfactory results according to clinical statistics. That's why it's still adhered to. And basically, you've got 5 types, 4 describable, and the 5th is a mixture of any one of them. So you've got 1, again, a protruding type, just like in Ming classification for early gastric cancer, that was also protruding. So here also it is protruding. See, these are basically the layers of the gastric wall in different colors. In Borman 2, it is now like a bowl, right? Katori ki tarah. It's basically bowl. And what else? The edges are raised. 2 things to remember: elevated margins and excavated. It's gone deep into the deeper layers. Deeper layer. Mucosa, submucosa, muscle, and serosa. So it's gone up to the muscle layer. This is the muscle layer, right? So relatively clear boundaries still. That means surrounding infiltration is still not there. So elevated bowl shaped ulcer. 3 things to remember, Borman 2. Bowl shape, elevated margin, and relatively clear boundary between the cancer and the surrounding environment. So number one, remember one thing, it is a broad-based polypoid carcinoma. Broad-based and polypoid. Number two, very easy to remember, bowl shaped, elevated margin, and non-infiltration. Okay, Borman 3, now with the central ulcerating lesion, the elevated margin had disappeared. And in addition to this, infiltration occurs. Is that clear? So the difference between 2 and 3 would be simple. Number one, the elevation disappears and the infiltration occurs. Here, elevation, no infiltration. Here, no elevation, infiltration positive. And Borman 4 is a generalized diffusion, no excavation, and so almost a flat lesion, but extending for a varied area, over a larger area, you have infiltration of the surrounding mucosa. Right? Type 5 is basically a mixed type of presentation of Borman. So remember, these 4 methods are the 4 types of Borman in the Borman's classification: 1, 2, 3, and 4. Okay. Now this is basically the complete classification by the WHO for gastric cancer. Also include early gastric cancer. This is the Ming classification. But if we talk about the advanced gastric cancer, we adhere to 2. Number one, WHO classification and Laurent classification. The Laurent classification, one classification which is adhered to very strictly. Why? Because it's got an important prognostic implication. You can prognosticate a patient, and it also tells you what kind of treatment probably to be carried out. And among these, the intestinal and diffuse and unclassified, we'll be talking about that in one of the future slides. And then you got the WHO classification. Now let's talk about the WHO classification. Basically, it classifies into 5 main types of adenocarcinoma: the tubular, the papillary, the mucinous, poorly cohesive, and mixed carcinoma. The tubular, as the name suggests, is very, very simple. You're branching tubule-like, basically in the, these are, look, this is basically microscopic. We're no longer talking about the macroscopic. Macroscopic gone, Borman's. Now we talk about the microscopic. So microscopic on a cut section, on the microscope you see the branching tubules. That's why it's known as the tubular. In papillary, the growth grows outward from the stomach wall and contains finger-like growth that is macroscopically seen. And also on the microscope, you see they look and behave much like normal cells, right? They look like, so you'll find that ingrowing of those finger-like projections into deeper into the layers, and you'll find them surrounded by normal cells, more or less normal cells. Mucinous, there's a lot of extracellular mucin. Remember, not intracellular, it is the extracellular mucin. Poorly cohesive, these are basically a signet ring type of carcinomas, and they are, you have the clump-like cancer cells arranged in that field on which you're studying, right? So the field under a microscope will show a lot of clumps of cancer cells. And mixed carcinoma would be having mixture of one or two or more of these types of malignancies. But coming to Lawrence classification. Lawrence classification is important to remember. Why? Because it can prognosticate a patient. You tell the patient, look, you've got this kind of a malignancy, your outlook is poor or your outlook is good. So the most common or the better is the intestinal type, named because you find intestinal metaplasia in this patient. Diffuse is basically, fortunately, 33%, but unfortunately, with a poorer prognosis. And if you see the differences, you find them in any of the books. I'll just point them out, the important ones. And these are basically, you can find recognizable pre-cancer lesions in intestinal type. Look, the age difference is also very important. Younger age group, and here 70 to 80 years. That's basically a disease, intestinal basal disease of the old age group, and that's why it tells you that it is probably a better malignancy. The male and female ratio is again altered in favor of the female. The males are more, and here it's almost equal. Okay. Now, recognizable precancer lesions in intestinal type, here you don't find any precancer lesions. Distal stomach and proximal stomach, I showed you the first sketch in the first or second slide. I showed you that the diffuse type is more common in towards the esophageal junction or the proximal stomach, and this is more common in the distal stomach, right? And I said earlier, this is decreasing incidence worldwide. The proximal, there's increasing incidence worldwide. That was shown, that clearly depicted in that sketch, right? There's expansive, slow growth, and that stands to reason. Intestinal, they got better prognosis, they're slow growing. This got a poor prognosis, that's why it's fast growing, and more infiltration. More infiltration. So if we look at the Borman's classification, probably Borman 1 and 2 would be more like intestinal, and the rest 3 and 4 would be more like the diffuse type, because 3 and 4 you find infiltration. Clear? Well differentiated, poorly differentiated. Again, a reason why they are poor prognosis. Small uniform signet ring cells are very common in diffuse. Right? Here it is basically glandular structure resembling the normal mucosa. Diffuse inflammatory cells are infiltrated. You find them infiltrating. There's infiltration. Again, a point in favor, because once you get an infiltration of any malignancy with the lymphocytes, so T and B, that basically tells you that there is a mounting immunity against these malignancies. So it's a good sign. Spread by hematogenous, this is basically direct invasion. H. pylori, you'll find this, no macrosatellite instability, APC gene mutation, and all these genetic factors are working out here. Here is only probably less genetic factors, and the mixed type is seen in almost 14%. So you can have a mixture of intestinal diffuse, or you can have intestinal, or you can have diffuse, right? Now, there's another classification, that the Gopsi's classification, Gosecki's classification, and there is just nothing but the showing the pattern of differentiation. So you got well differentiated with intracytoplasmic mucin. This is intracytoplasmic. Remember, we just talked about what? Extracellular. This is intracellular. So well differentiated, minimal intracytoplasmic mucin. Type 1, type 2, again well differentiated, but the mucin has increased. Type 3, poorly differentiated, less mucin, poorly differentiated, more mucin. So it's just simple types of 1, 2, 3, 4. That is basically again a method for deciding on the prognostics of this malignancy. The molecular subtypes, that is again becoming important. You'll find this being mentioned in almost all textbooks. And these molecular subtypes, why? Because they also are helpful in prognosticating and method of treatment, slightly different method of treatment. Look at them. EBV positive, Epstein-Barr positivity, carcinoma with lymphoid stroma. So that basically you find in a medullary type or a lymphoepithelioma type. The lymphomas, you'll find the EB positive. Genomically stable, the genome is complete set of genes in a living cell. You'll find there is stable, not much alteration in the genome. But chromosomal instability and macrosatellite instability are two molecular subtype that you can easily identify in gastric carcinoma of the genetic variety, right? Microsatellite, we already referred to it, that these are fragments, the DNA mismatch repair gene is not working properly, so they got microsatellite instability. Because DNA replication, small fragments occurs in every individual. Every individual. I have it, you have it, everybody has it. But what is happening is that there is a DNA mismatch repair gene which keeps on repairing these fragments. Now that gene is missing. So the unstable mismatch repair gene. So an unstable MMR, that's why they are basically doing what? They are persisting for a long period of time. Chromosomal instability. So these are fragments which are making the chromosome. Now here we talk about the whole chromosomal instability. So either fragment of the chromosome is not replicating properly, that is the DNA, then microsatellite, or the whole chromosome is not replicating properly, right? That makes it the chromosomal fragments are abnormal addition or subtraction of the chromosomal fragments, total fragments, not only DNA, a total fragment. That will be chromosomal instability. So it's very easy to remember, nothing very difficult about it. The range of mutations in genes related to genome is also there, right? You have integrity, chromatin remodeling, cell addition modeling. So you just remember that range of mutation of genes is also there related to genome, is also found in a sizable population of patients with genetic gastric cancer. Mutation of cell signaling pathways, again very important. Why? What is the importance? I just not told you the importance. And the importance is that they may help in targeted therapy, including immunotherapy. So understanding this alteration of the molecular subtypes probably helps or probably would help you later when immunotherapy comes up in a big way for the management of gastric cancer. And that's what we're trying to understand. That's what they're trying to understand. That if these are altered, can we somehow manipulate them to take care of the genetic gastric cancer and get rid of it? That is immunotherapy. So they have got a major role. Understanding these molecular subtypes has got a major role to play when you're starting to understand immunotherapy of gastric cancer. Right? Now let's look at the spread of gastric cancer. The spread of gastric cancer, hematogenous, we all know that all malignancy in the stomach ultimately land up with the liver. Why? Because the whole portal circulation deals with liver. But beyond the liver goes to the lungs and the bones. Again, very, very simple, understandable. The lymphatic mechanism is by permeation or embolization, and the site perigastric and then even distant lymph nodes. Supraclavicular, if the Trocheus sign is there, because almost all of the malignancies inside the abdomen can, by permeation or by embolization, can go up to the left supraclavicular lymph node that we know. And that's why examination of supraclavicular lymphadenopathy is very, very important in any kind of abdominal lump when you're suspecting malignancy. Implication is very important that lymph node positivity does not mean a systemic spread, right? It is a lymph node spread. You don't take it as an M stage unless until you've got N3 or N4, right? So unlike in breast that you consider it to be a generalized metastasis, that's what you consider when you talk about breast cancer. We're not going to the breast cancer, but one of the major concern breast cancer, as soon as you have the axial lymph node positivity, is probably a disseminated. It's basically a disseminated breast cancer. Not so here. That's different. And then, of course, the direct into the layers of the wall of stomach, and from there to an adjacent structure. So that is T4 stage, and T4 basically when it's gone beyond the walls of the stomach, perforating beyond the serosa and into a organ. Now, again, T4A and B, we just talk about that, is a different proposition, right? But perhaps one of the important methods of spread of gastric cancer is the transperitoneal, transcoelomic spread. And where does it go to? Number one, parietal peritoneal seedlings. You find them studded all over the peritoneum. You find the Sister Joseph's nodule. Again, it is a peritoneal spread where you find these nodules all around the umbilicus, periumbilical nodules spread through the ligamentum teres. Greater omentum, where you have the palpable omentum as an omental cake. You examine this patient, you may not be able to palpate the gastric lump, but you will be able to palpate a transversely growth which is irregular, or a lump which is irregular, which could be a omental cake. So that is found even in tuberculosis and found even in malignancy, which is metastasized to the omentum, great omentum. Rectovesicle of pouch of Douglas, and you find the 4 stages of peritoneal the metastasis in the pouch of Douglas. I've been repeatedly telling you about that. I'll just repeat that. Stage 1, when you're doing a per rectal examination or DRE, or doing a per vaginal examination, stage 1 metastasis to this pouch is what? A single nodule. Stage 2 is multiple discrete nodules. Stage 3 is what? Confluent nodules, right? And stage 4 simple is a Blummer shell, where the whole thing is so much deposited that is pushing the anterior wall of the rectum into the lumen. So that when you're doing a DRE, when your finger goes in, you feel that there is some kind of a shelf out there. And then you try to negotiate your finger around the shelf and then reach the upper part. So that is a shelf-like projection in the anterior wall of the rectum. That's why it's not the Blummer shelf. It is also spelled as a, apart from U, you can, instead of U, you can put in a O, Blummer shelf, both are correct. A Blummer shelf or a Bloomer shelf, both are terms which are taken as correct terms, right? So remember, discrete nodules, multiple discrete nodules. So one is solitary discrete nodule, multiple discrete nodules, confluent nodules, and number 4, a shelf-like projection of the anterior wall of the rectum. That is true for any kind of peritoneal metastasis into the pouch, whether it's pouch of Douglas or rectovesical pouch, depending whether it's a female or a male. In all these, you'll be having these 4 stages of metastasis into the peritoneal of the rectovesical pouch of Douglas, right? Now comes the important part, that is the ovarian. In females, a gastric malignancy can give rise to ovarian lump. And there are 2 types of ovarian lumps. Number 1 is the Krukenberg's tumor. Now, Krukenberg's tumor is not every ovarian metastasis from a gastric ulcer. Remember that. It is only the surface metastasis or the surface seedlings of an ovary. That means the transcoelomic, the malignant cells are falling on the ovarian surface and they give rise to the seedlings on the ovary. That is Krukenberg's tumor. The other method, ovarian spread, is what? It is a retrograde blood flow from the Batson's venous plexus. You know what the Batson's venous plexus is. So that means the hematogenous gives rise to backflow from the vertebral chain of veins back into the ovarian. So this is basically what here in a retrograde flow. If this is the ovary, in one it is coming like this. This is the blood vessel, right? The artery and the vein. So it's coming through the vein retrograde. The vein is supposed to drain like this. It is coming like this. So the core of the ovary is going to be affected. And in the other, it's the surface of the ovary which is being affected. So when the surface of the ovary is being affected and seedlings, naturally you're going to feel an irregular lump. Very simple to understand. A large lump which is irregular. Why? Because the multiple seedlings are around. When it's going inside, it's going to expand the ovary for you. If it's going to expand the ovary, it will be a smooth, large ovarian lump. Very easy. Okay. So in the Krukenberg's tumor, you're basically having a irregular nodular large, and it could be at any age. It could be an old lady, it could be a young lady, whatever. The ovary is always there. But when you want to understand the retrograde flow through the veins, remember with passing of age and menopause and postmenopausal age or era, what happens? The blood supply gradually shrinks. And because the blood supply shrinks, you have atrophic ovary. So in an atrophic ovary, you don't expect the retrograde flows. So if you have to understand the ovarian metastasis in a gastric cancer, it is more likely in the old lady, it's more likely to be what? A surface Krukenberg's tumor. And in a young lady, it could either be surface or it could be through the core of the ovary. Is it clear? So in the surface variety, any age group, that's why at any age. And if it is spreading through the retrograde blood flow, it is not usually seen in the old age. That's the whole atrophic ovaries, and gives rise to smooth pelvic lumps. And that's why more common in the younger premenopausal patients of gastric carcinoma. Is it clear? It's very simple to understand if you understand what is really happening without just going in and trying to memorize it. Now coming to the most important. You thought that the lymphatic spread was gone with those 3 lines. I thought probably, and I believe most of you thought that the lymphatic spread was over. And that's the end of lymphatic spread. No, sir, it's not. Let's try to understand lymphatic spread. Why? Because that is now the cornerstone of therapy, cornerstone of surgical therapy of any patient with gastric ulcer. I was searching through the net and I found these very interesting photographs which I picked up from the net. I've shown where you can find them on the net if you want to go there, but you can take it from this. And there are 3 figures. The first one, let's talk about the first one. And this is the line along the greater curvature, dividing the stomach into 3 important parts, 1, 2, and 3, right? 2 along the greater curvature and 1 along the lesser curvature. This is part 1, part 2, and part 3. Now let's skip to this particular area. One thing you need to remember is that the total lymphatic flow of the stomach, total, is directed to one central point, and that is the celiac group of lymph nodes. Celiac group of lymph nodes. Whether it is coming from the proximal part, from the OG junction, or it's from the pyloric part, ultimately all of them are going into the celiac. From here, it's going to the splenic, no doubt. Short gastric, no doubt. Gastroploic, no doubt. right gastrofloid lymph node, no doubt. But ultimately, where is it going? Is going to the celiac group of lymph nodes. So that is one route that's taking. The other route that's taking is basically from the infraduodenal, that's the infrapyloric area, right? This is the pylorus, the first part duodenum. From these lymph nodes, the gastroduodenal lymph node, it goes to the superior mesenteric lymph nodes, 14A and 14B. That's the vein and the artery, right? It's depicted very carefully or very clearly out here. So see, this is the aorta, this is the celiac axis, right? You have the gastric, you got the splenic, and then you got the hepatic, common hepatic. Okay, not very difficult to understand. Now, here, see what's happening to all along the pancreatico-splenic lymph nodes. Yes, gastrofloid, short gastric. Even from here, where is it going? See the drainage channel. Every arrow is going towards this. Every arrow going towards this, right? So, one thing you need to remember is that the whole stomach, the lymphatics, they ultimately drain into the celiac group of lymph nodes. Okay, so that forms a very important central point. Okay, and this infrapyloric part can partially also go to the superior mesenteric lymph. And that's why see initial drainage, secondary drainage. The initial drainage is all toward the regional lymph nodes. Okay, and this secondary drainage from there, it is all concentrated toward the pyloric group of lymph node. Now that's not all. That is just the initial figure I wanted to show you so that you can understand it much better. Now the draining lymph node, this was basically the purview of the Japanese because they came up with this and they defined these lymph nodes and they showed that if we understand the lymph node this way and try to remove the lymph nodes along with the malignancy, that would be a block, sort of a block dissection, then we would be getting much better results rather than just picking up the stomach and removing it en bloc just by the cutting the margins, less momentum, greater momentum, just removing. No, that should not be the norm. And that's why way back in 1973, they defined 16 groups that the Japanese research organization, which was later on known as the Gastric Cancer Association, Japanese Gastric Cancer Association after 1997, and they defined 16 groups. But the 218, which is the latest, now this is the latest which has come up, and that's you don't have anything beyond 2018. So 2018, they came up with the 8th American and the Japanese classification, and they showed 20 stations. The station basically means 20 primary groups of lymph nodes, right? Now, 20 stations, they together make up 33 or 34. Why 33 or 34? 33 basically because number of these, they've got A and B to it, A, B, and even C. And 34, why? Because now they're dividing the group 3 into 3A and 3B. 3A, 3B basically mean the left gastric artery and the right gastric artery. I'll just show you figures so you can understand much better. Now, they further divided into 3 N groups, N1, N2, N3, with respect to location of the primary groups, right? And this basically is important to define the various D resections of curative resection. You must have come across these terms, D1 resection, D2 resection, D3 resection. If not, then you have to. You have to. Why? Because if you understand what is the D1 resection for gastric cancer, what is D2, what is the D3 resection, especially you have to understand what is the D1 and D2, because that is basically the cornerstone of all surgical therapy of gastric cancer today. Okay, so the first station basically is what? The immediate perigastric group, which contains lymph node stations from 1 to 6. Second station on blood vessels, see, perigastric and blood vessels. That makes you understand it much better. That is around vessels supplying the stomach. That basically means what? These would be, see, these are the vessels. Okay, these are the vessels. So this would perhaps be the second group, the regional, and this would be the perigastric. Have we another figure for this? Gastric draining lymph nodes. Regional stations 1 to 12, then 40. Okay, these are known as distant station, and they now become classified as M1. What did I tell you just now? That the lymph node metastasis would not be taken as a generalized metastasis until and unless they go up to the N3. So this is basically talk about N3. Talk about lymph node stations like 60, 90, 10, 110. And these have to be considered when you're talking about the esophageal tumor. So second tier or third tier of lymph nodes may be concerned as a M stage. Now let's see what we are basically meaning. Now this is just you can go and have this this chart. You can have it anywhere. Now let's go and look at the first tier. That is a very important diagram, and this would help you to understand everything. Now, if you want to remember the lymph nodes, I'll give you a very easy method. You take a line from here and zigzag it. Go here, come back here, go here, come back here, and come back here. So 1, 2, 3, 4, 5, and 6. Simple. If you want to remember, 1, 2, 3, 4. From 4, then again 4 everything. Then you come back again medially 5 and then 6. Easy to remember. Nothing problematic about it. So these are the basic perigastric lymph nodes. The 5 anatomical regions we're talking about. And see, 1 and 2, 3 now recognize as 3 and 3B. 4 has got 3 groups to it. A, B, and D. I'll just tell you what they basically mean. 5 and 6 present the perigastric lymph nodes. So these are the perigastric lymph nodes. Okay. Now 1 and 2 basically are the cardia. Okay, the cardia. 1 on the medial side, 2 on the lateral side. Nothing problematic about it. The right cardiac and the left cardiac. 1 and 2. Now 3 are basically the lymph nodes along the lesser curvature. And which vessels are we talking about? See, this is the celiac trunk. This is the left gastric. Okay. Spleen coming from here, going underneath, and booty coming to the spleen. Okay. And this is basically what? Anybody? Common hepatic. This common hepatic gives out what? The right hepatic or the hepatic, and then gives out to the gastroduodenal. Right? Now the gastroduodenal, you have the right gastric. So right gastric and left gastric. That makes an arc around the lesser curvature. And that is basically the 3 and 3. So 3 we understand is basically lymph nodes which are found around the left gastric and the right gastric. Easy. Okay. Now cardiac, easy, 1 and 2. Now what about 4? 4 are basically the lymph nodes which are found along the greater curvature. Along the greater curvature. See, it's not including the spleen. And what is 4SA, 4SB, 4D? Now SA and SB basically, see, SB is what? Gastria brevis. Okay. Now basically brevis basically is short gastric. Okay. So that is the short gastric vessel. Then we come to the gastroepiploic, and that is again 2 groups. This is basically the APS means the Phrenica inferior sinistra. Now what does sinistra mean in English? Sinistra and dextra. Just a short English lecture for you, just 2 lines. Sinistra basically means sinister, something which is dangerous. And dextra means dexterous. That means you are good at doing something. Now, when these terms were taken from Latin, just to make you understand what they mean, you'll never forget it. Just to make them understand, when they're taken up from Latin, something sinister. Now, everybody used to be right-handed person at that point of time, right? If they found somebody left-handed, even I don't know, 15 or 20 years back, if you saw a left-handed person, he said, look, he's left-handed. That's not good. He should work from the right. Why should he work from the right hand? That is basically the thing with the patient or the person. I mean, he is tuned to have a left-handed, but then it was considered to be bad or sinister. That's why whenever you find a sinister term, it would mean left. Dextra, a person who is basically ambidextrous. What is ambidextrous? Both right and left hand, right? So right hand is a dexterous person. That's why dextra. So if you have gastrocleploica dextra, that basically means right epiploic. Okay, that's right gastrocleploic. If you have the sinistra, that basically means the left. So here see epiploica sinistra, that is basically out here, and the dextra is basically out here. VGED. This is VGED. This is the right gastrocleploic. This is the left gastrocleploic. Is that clear? Because both of them are coming from where? The splenic artery. This is a splenic artery. You got the short gastric vessels and you got the left gastrocleploic. Left gastrocleploic is the sinistra. Okay, so gastrocleploic sinistra. So, and 4D is what? Along the right gastrocleploic, the second branch, the distal part of the vessel. This is the distal part of the vessel. That's why 4D. So basically, we are talking about the perigastric glands. When you talk about the perigastric glands, we are talking about 3, 1, 2, 3, and 4. That leaves what? The suprapyloric and the infrapyloric. That makes 5 and 6. Easy. Now you remember the perigastric glands. Remember that. 1, 2. Gone from here. 1, 2. Make the Z. 3. Bring the flat of the Z. 4. Come down. Take it up again. 5. Come back down. 6. Easy, right? I hope you don't forget it. That's how at least I remember it. So maybe it will help you. So just try to do it that way. So this is the first group or the N1 group. Okay. Now see, we have missed out on what? We have not included 7, 8, 9, which is seen out here. Why? Because the second tier. They're second tier. Now these are the vascular groups. The lymph node groups are on the major part of the vessel from there when they are arising from the celiac trunk. Now let's see what these are all about. These are basically 7, 8, 9. See 7 along the left gastric nodes, and where? Between its roots from the celiac trunk till the origin of the ascending branch. See, this is the ascending branch. Can you see the ascending branch of the left gastric? Important. You have to remember this when you talk about gastrectomy. I'll bring this figure up again when we talk about gastrectomy. Right? Very important. So here what's happening? The left gastric, the descending branch and the ascending branch. Now, when it comes to descending branch, we're talking about what? 3. That's 3. But when you take the basic left gastric, the from which the arising of the left of the ascending and descending branch, that particular segment of left gastric, any nodes out there would be 7. Okay. Similarly, from the celiac trunk, if you have the common hepatic, that's the common hepatic. Sorry. If there's a common hepatic, that will group 8. So now we know 5, 6, and where are 7, 8? The left gastric and the common hepatic. And what is 9? 9 is basically the celiac trunk. Easy or difficult? Easy. You just have to go over it. Simple. Along the curvatures, along the pylorus, you have from 1 to 6. Very easy to remember. Then the major blood vessels supplying, you have 7, 8, and 9. 7 left gastric, 8 is the common hepatic. Why common? Because from there the hepatic artery and the gastroduodenal arises, and 9 is the basic vessel from where everything is coming out, at the celiac trunk. Now from here, remember what is coming out from here. What is this vessel? The splenic is going from here underneath and going out here. Along the splenic, you have got group 11. The splenic artery nodes are 11. So now we counted for what? 7, 8, 9, and we got 11. So that leaves only 10. Let's see what 10 is. 10 is basically when the splenic comes out here and you got group of lymph nodes in the spleen. That is group 10. Okay. Now see, this figure is very, very good. I brought this figure up because that's a very interesting figure and very helpful figure from the Japanese Research Society. It's an article from them. And see, this is the celiac trunk. Okay. Celiac trunk, gastric, celiac trunk, splenic, celiac trunk, common hepatic. Okay. So common hepatic, we just now said group 8. Left gastric, we just now said 7. Ascending branch, descending branch. Okay. We saw that vessel going under the stomach. 11. And we said termination 10. And then 12. Any difficulty? No. 1, 2, 3, 4, 5, 6. Then here, because this is junction lying out here. 7, 8, 9. Right? Then coming back to 10, 11, and 12. What is 12? When the hepatic artery divides into right and left branch, these are basically the nodes we found in the lesser omentum towards the liver. Clear? So at least you should remember these group of lymph nodes. Why? Because D1 and D2 gastrectomies are concerned with this group of lymph nodes. You may not remember the other ones, 13, 14, 15, 16, so on and so forth. You can afford not to remember them. You can afford to do that. But otherwise, we remember them very good because it's basically understanding going. I mean, this is not just the name, this group, this group, this group. This is basically an orderly fashion which they have named them. And if you understand the order in which it's named, you can easily remember them. I showed you the order in which this is named. Okay. Now, see, this is another very good figure. And this shows you the N2 groups. And see again, celiac trunk. Nothing very difficult about this. Splenic artery, spleen. A repetition I just now said. 11, proximal and distal. 11P, proximal splenic. D means distal. And group 10. See this greater curvature? All four. All four. SA, SB, 4D. And the lesser curvature 3. 1, 2, 3, 4. And then the 5, see the 5 and 6. Suprapyloric and intrapyloric. And then we talked about what? 8, 9, 7, 8, 9. 7 gastric, 9 celiac, 8 common hepatic. Okay. Now, we just now said 12. 12 was what? The part around the porta. See this hepatic artery going? This is common hepatic. The hepatic gastroduodenal, from which you have the superior pancreaticoduodenal, and you got the right gastric. See the right gastric coming out here? I'll show it in another figure. This was the reason why I didn't touch on the lymphatics in the anatomy when I started the lecture part 1. When I did stomach part 1, I had not touched upon the lymph node because it would have been wastage trying to understand. We would have forgotten when you came to this part because it's more concerned with this part where you should remember these lymphatics. That's why I've taken this purposely, put this purposely in this part of the lecture. Even the vascularity, I didn't touch on the vascularity in first lecture. Remember that. I've again touched on the vascularity in this lecture. Why? Because that explains how you're going to cut the stomach up. Okay. So this is how you name them. 13 is again behind the pancreas. I don't think we'll be trying to waste time with that, but this is just how it looks like when you remove the stomach. This is how it looks like, and you got basically the celiac trunk. Let's forget this, but this is again the same picture. You can pick this up, but I've tried to make you understand. So if you look at the normal untouched anatomy, it looks something like this. The celiac trunk lies where? Medial to the lesser curvature. You can see the pancreas. This is the pancreas, and from here the left gastric, the common hepatic. And you can see basically below down the superior mesenteric. It's not celiac, below it's the superior mesenteric. It's a different vessel. A different vessel coming down, going behind the pancreas. So second tier, I already talked about the 10, 12, the 13 retropancreatic. I'm not wasting time out here. This is again the same figure which I have put out here. See, this is different. Celiac, this is the superior mesenteric. Here is the mesenteric coming out here, 14A. That's the artery, and here is the 14B. That's the superior mesenteric vein. So that is 14. 13 is behind the pancreas. So 13, 14. So we remember everything. We remember what? We remember up to 14 now, right? 16 basically C base, 16, 15, 16. This is basically the aorta, and this is what? The aortic what? Diaphragmatic opening. So that is basically around the diaphragmatic opening. Go and look it up. I won't be wasting time on it. But coming with the TNM staging. Okay. So now we know the important lymph nodes at least for D1 and D2. Now let's come to the alteration or the changes of definition TNM staging, which had come up in 2016, and is also this the eighth new eighth classification has come up. There's nothing more than 8. They don't have any 9. 8 is the latest. Now 8, the changes they have defined, two important changes. Number one, that they have defined the esophagogastric junction adenocarcinoma, and the Sievert 1 and Sievert 2 were defined as the esophageal cancer, and Sievert 3 was now kept as a gastric cancer. Now you'll be saying, I'm done through my head, what is Sievert? We don't know what Sievert is. I'll just show you, don't worry. But any perforated gastric cancer was straight away T4 gastric cancer. That is an important difference. If you have a perforation, let's say a gastric perforation, and you find this to be gastric cancer, it is straight away T4. Nothing to decide on that. It's T4. Why? Because obviously it can only perforate when it is burrowed right up to the serosa and gone beyond the serosa. Only then it perforates. So you need to understand. So any perforation in a malignancy of the stomach is T4. And Sievert 1 and 2. Now see what's Sievert. Sievert classification for O genes. Now, Sievert 1 and 2, basically this figure is very, very representative. You take anything. So if this is the anatomical cardia, 2 centimeters below, and between 2 and 5 is the only gastric cancer. If you have this is not a gastric cancer. That means 2 centimeters up to 2 centimeters below the gastroesophageal junction, which you're talking about, considered to be esophageal cancer. Very simple and very easy to remember. Is that clear? So any malignancy of the esophagus or of the gastroesophageal junction, which has got an involvement of up to 2 centimeters of the cardia of the stomach, is to be considered as an esophageal cancer, not a gastric cancer. Is that clear? That's why we said Sievert type 3. This is basically Sievert classification, type 1, 2, 3. Type 3 is subcardinal carcinoma, which will infiltrate the gastroesophageal junction from below. It may go above, but the epicenter is here. We're talking about the epicenter. You know what the epicenter is? The main part of the malignancy from where the malignancy spreads. So the epicenter is between 2 and 5 centimeters. Okay, so the epicenter here, it may spread upwards, but the epicenter is here, so it would be a gastric cancer. That's why it's written type 3 gastric cancer. Is that clear now? So that is the change which has come up in the 8th classification, and that is they consider the esophagogastric adenocarcinoma as Sievert type 3, only type 3 as a gastric, type 1 and 2 as esophageal cancers. Okay, now coming to the TNM staging. Again, very easy to understand. I've tried to show it. I've depicted it very clearly. This is the epithelial cell, the lamina propria, and the muscularis mucosa. I told you this total is what? Mucosa. Mucosa total is 3 layers: muscularis mucosa, lamina propria, and epithelial cell layer. Clear? So if it is only in this layer, it is T1S. Okay. The lamina propria and muscularis, I've shown the arrow, T1A. Goes in the submucosa, T1B. Clear? Nothing very problematic, easy to remember. So T1 in totality is mucosa and submucosa. Submucosa only, T1B. The rest of the mucosa along with muscularis mucosa, which is part of the mucosa, is T1A. T2 muscular layer, T3 serosal layer. It is going through the T3, gone beyond the serosal layer, T4. Simple, T4. T4A and T4B basically bursting through the Up to the serosa, 4A. Gone beyond the serosa, T4. Okay, so it invades the serosa, 4A. Gone beyond adjacent structures, T4B. So that's the T classification. The N classification is now again simplified. Initially, there are a lot of malignancies where they used to define them by specific groups, but now they've given it all up. They say, even if you remember when we talked about carcinoma of the gallbladder, we said now they're counting the lymph nodes. They're counting the lymph nodes. So here also, in N1, they're counting the lymph nodes. 1 to 2 regional lymph nodes involved, N1. 3 to 6, N2. Anything 7 or beyond is 3A or 3B. 7 to 15, 3A, 3B, 16 or more. M0, M1. So now they have probably simplified the classification. Right? And then together you can group them and come up with the various stages. Just go and remember these stages. I won't be wasting time on them, but just remember that whenever you have A or a B, 2A, 2B, and 3, basically concerned with the N type. So all N0s, 2A, N1, 2, 3. N1 to 3. When you talk about 2B, you increase the T stage and you bring the N back to normal, N0, N0. See, the T stage has increased. 2A is T1, T2, but N1, 2, 3, N1, 2, 3. But when you come to 2B, T3, 4A, they've increased, but N comes back to 0. So that is basically how we try to remember them. If you want to remember them, that's how you should remember them. Coming to the symptoms of gastric carcinoma. The symptoms, the mnemonic, always remember loads. You combine this word LOADS, that is loads. L stands for the lump. O stands for obstruction, which basically means gastric outflow obstruction, either partial or total. A stands for asymptomatic, and these are patients who are basically absolutely, they have no symptoms. You do an OGD and you find the malignancy. Like for example, early gastric cancer. D is dyspepsia, when the patient presents with peptic symptoms, dyspepsia, the burning, the bloating, and the heartburn, etc., etc., etc. And S is basically secondaries, when the patient presents with, let's say, secondary in the liver. Precocious secondary, you're not able to diagnose the malignancy, and you just find a large liver lump with multiple metastases. So that is precocious secondary, right? So secondaries, dyspepsia, asymptomatic obstruction, and lump. Now you won't forget it. Remember the mnemonic LOADS, and remember all symptoms of that. So the preoperative buildup is very important. The preoperative buildup, basically the routine pre-op investigation, that is LFT, KFT, and so on and so forth. Let's talk about the specialized ones. I'm not wasting on CBC and etc. etc. Patient, of course, will be anemic to a certain extent. Now, specialized, the endoscopic ultrasound should be performed by experienced person, probably one of the very important investigations. Why? As I told you earlier, it will define the T stage for you. It will define the early T1. Early T1 will not be defined even by a probably CT scan. May not be so beautifully defined even by MRI. It is better defined by a EUS. That's endoscopic ultrasound. So the various T stages would be better defined by EUS, and then high resolution CT scan of the chest, abdomen, and pelvis. Together, they'll help you to decide whether the patient has got M1 disease or not. You find evidence of metastasis in the chest, you find evidence in the pelvis, you find abdomen, the local regional, that is the abdominal lymph node, in the pelvis that shows the transcoelomic spread, chest that basically tells you it has become M1 disease. Simple. So staging laparoscopy is a very, very important method of investigation, which unfortunately we don't do. That should be done always along with or without cytology. If the fluid is there, send it for pap stain. If you find any evidence of doubtful malignancy, take a parietal peritoneal biopsy from a doubtful area. So with or without cytology or a peritoneal biopsy is a very, very important part of a pre-operative buildup of this patient. So what are the principles of management? Principle of management, I told you early gastric cancer, T1, N0. Just to repeat, you can do an endoscopic management, that is EMR and EST. But anything with N positivity, even with T1 or T2, any N operable gastric cancer, one of the following two treatment sequences. Remember what's written? Operable. That is definitive operability. The following two treatment sequences. Number one, you do surgery and follow it up with adjuvant chemotherapy or chemoradiotherapy, as you would like. We'll tell you what radiotherapy is about. Or you can do a perioperative systemic therapy and then follow it up with surgery. So that means you do a tumor deloading or a tumor reduction or stage reduction kind of a chemotherapy, and then go ahead and do a surgery. Like for example, you do a downstaging, like in breast. The patient comes with T4, you give this patient chemotherapy, it changes to T2, and then you go ahead and do surgery. So it's downstaging of the tumor, which may be required in certain patients, but by and large, the early stages of advanced gastric cancer, when you have early N1 or N1 or N2 with T1 or T2, they can hope to go in for early surgery and then follow it up with adjuvant therapy. But you've got advanced gastric cancer with late stages N, or you got a proximal gastric cancer, like for example the cardia involved, or you got linitis plastica, or you got a borderline performance status in a gastric cancer. These cannot be treated with primary surgical therapy. There you have to go in favor of a perioperative therapy. That basically means initial chemotherapy to be followed up by adjunctive surgery. So here surgery becomes an adjunctive therapy. There the surgery, here the surgery is primary. The chemotherapy is adjunctive. Here it is primary is chemotherapy, right? So primary chemotherapy followed by what is also known as induction chemotherapy to be followed up by adjunctive surgery. And that is required. Why? Because if we go in for primary surgery in these patients, you're having a prolonged operative recovery and a higher operative complication rate, which does not serve the interest of anybody, neither yours or the patient. So don't go ahead and jump into the with the patient. I say I have to do surgery in this. I have not done surgery for a gastric cancer a long time. No matter it's T3 or T4, whatever proximal, I'll try to remove it. No, not correct method. Okay. Operability. So how you decide you're going to operate on this patient? The patient really can be operated or not? Now that can only be decided on a CT PET or a PET CT taken together or a pre-operative laparoscopy. Three things very, very important before you go ahead and decide on the operability. So it is inoperable. You don't operate on such a patient when number one, hematogenous spread is there. Number two, distant peritoneal mets. You find a pouch of Douglas or a rectovascular pouch metastasis. The Blumer shelf is there. Does it make any sense to carry out any kind of curative resection? No, you can only go palliative therapy. So distant peritoneal mets, N3, N4 or beyond. I told you N3, N4. T4B. We said T4B is basically what? It has broken the confines of stomach and had gone into the surrounding organ and become non-removable fixed. Now fixed does not mean non-removable. There are instances where even transverse colon could be removed along with the gastric cancer that is given a excisable gastric cancer. So what is important? Non-removable fixation. Fixation which is removable or non-removable. That's why non-removable fixation of those adjacent structures. What is controversial in this incurable? N3, N4. We said N3, N4 or beyond. Incurable. No. In Japan, they say no. It is operable. So that is the controversy. A Japanese surgeon will not consider N3, N4 as incurable. He'll consider it to be curable. T4B, that is fixative, a fixed malignancy, adjacent structure involvement, if removal, can be removed. So these are the two controversies, N3, N4 and 4B. These are the controversies that if this fixation is removable, go ahead and do it. N3, N4 is a Japanese surgeon, go ahead and do it. If you're a Western surgeon or Indian surgeon, don't do it. Right. So surgical resections could be in the form of, all of them have to be R0 resection. Now the term R and D is now going to coming up increasingly, right? Now R0 basically means what? R0 means that there is microscopic, no evidence of malignancy in the cut edges of your specimen. So that means you've gone beyond the microscopic extension of the tube. That is R0. We'll come to R0 again. So every malignant curable, any kind of curable surgery or curative surgery has to be an R0 resection. So R0 we need to understand no microscopic remnant in the cut section. Okay, endoscopy, we already talked about that. So R0 gastrectomy could either be subtotal gastrectomy or it could be total gastrectomy. Two types of gastrectomies which can be done for gastric ulcer. Now subtotal gastrectomy, when you're doing a subtotal, usually removing 80%. Remember the partial gastrectomy we talked about yesterday for ulcer disease? What do you say? Either 1/3 or half or maximum 2/3. That's 60%. Not more than that. Not usually required unless suddenly you got a very high gastric ulcer. So here it is always more than 80% removal of in a subtotal gastrectomy along with R0 resection, right? Now there is oncological excision. R0 is oncological excision, and you should have at least a proximal margin of at least 4 to 6 centimeters. That's what we're worried about. Distal we got the duodenum to play about. Proximal, whether we do have any remnant stomach remaining behind after excision, that is important. So you should have at least 4 to 6 centimeters of tumor-free tissue or stomach. Tumor-free. So 4 to 6 centimeter normal margin should be there before you go ahead and decide that I'm going to do a subtotal gastrectomy. And then once you've done that, the recontinuity is going to be done either as Billroth 1, proximal Roux-en-Y, Billroth 2. I'll just show you the next figure. So that is reconstituting the cut stomach. And this is usually helpful. The subtotal gastrectomy can be carried out if it's a middle third growth or it is a distal cancer. So if you got a stomach which has got the pylorus involved or the body involved, go ahead and do a subtotal. But if you got a major part of body involved and you got a higher end of the cardia involved, you can't do a subtotal. Then you have to go in for a complete gastrectomy or total gastrectomy. And after any gastrectomy, whether subtotal or total gastrectomy, you have to reconstitute. The food coming in the esophagus has to go down, and preferably it should be done by a Roux-en-Y and a jejunal. Now the problem when you're doing, now let's see, now here comes the blood supply of the stomach. That is where it's important. Why? Because when you're doing a partial gastrectomy, it is very, very important that you know what the vessels you're cutting. And why? For the simple reason, look, when you're doing a gastrectomy, partial gastrectomy, you're cutting this. Let's say I'm cutting this. I'm doing the whole thing and I just leave a small segment of the stomach out here. Now, when I'm removing this and I'm doing a D2, D2 basically means what? I am removing the N2 groups. What are the N2 groups? The lymph nodes found where? Here. See, celiac, left gastric, splenic, right? The right gastric coming here, and the common hepatic. That means I have to clear these lymph nodes. Now, if I have to clear these lymph nodes, I have to cut the gastric artery. Only then I will be clearing this lymph node. So that means I ligate it here. If I'm ligating it here, then what am I cutting? This whole supply. If I'm leaving this, now this part of the stomach is getting the blood supply from where? Only short gastric arteries. Nothing else. I've cut the splenic, I've cut the left gastric. So no part of that blood from the celiac trunk is coming to the stomach anymore. So the stomach is only being supplied by some phrenic, very small phrenic arteries and the short gastric artery. So the blood supply of the stomach, kindly close your mic. The blood supply of the stomach is basically the left gastric, the splenic, and the right gastric, which is a branch of the gastroduodenal. Okay, here is the pancreatiduodenal coming out, the gastroduodenal, and the hepatic. So the right gastric, and then from the superior pancreatiduodenal, you've got the right gastrophloic. From the splenic, you've got the left gastrophloic and the short gastric. That is the total blood supply of the stomach. Don't forget it. That's why I took up the blood supply here. I didn't take up the blood supply there because that is what is important when you're going for any kind of resection or partial gastrectomy. Okay, even for complete gastrectomy, but more important, partial gastrectomy. So what do we have to remember in partial gastrectomy? What is important? Important is that I just now said 80% stomach being removed and 4 to 6 centimeters of proximal margin tumor free and 2 centimeters of distal negative margin in the middle stomach growth. So the growth is here, growth is here. I can do a cut out here and I can just have this segment and see here's the left gastric, ascending, descending branch. I'm cutting it here. So this all goes, no vascularity here, only vascularity from these two parts. Some coming from the basically from the diaphragmatic vessels, a very minor part, but gastric, short gastric are the major vessels working out here because I'm cutting everything. So gastric flow is gone, the left gastric gone, the right gastric gone. What is remaining? Only short gastric. And that is why it is very, very important that you have to maintain the vascularity of the gastric stump based on the short gastric. Don't ever damage the short gastric. If you damage the gastric, short gastric, then what's going to happen? At the time we will do anastomosis and post-operative 101% is going to leak. Why? Necrosis, ischemic necrosis, no blood supply. On the table, you may not be able to decide the blood supply there or not, although you should be. You can see the oozing from the edges. You should be able to see that. But in your haze, suppose if you don't see that, you just go in and do an anastomosis. After 1.5 hours of surgery, you're so tired, you just say, let me do an anastomosis and let's hope for the best. The hope best is what? Leakage. And the hope for the best is with the leakage, the patient goes up. Right? So whenever you have to do a D2, that means extensive lymph node dissection. D2 basically means this. So you are doing extensive lymph node dissection out here. You have to cut the left gastric. And if you have to cut the left gastric, then you are in a very precarious position as far as the short stump of stomach is concerned. Is that clear? Is that clear? That's what I wanted to bring out in this particular figure. That's why I put the figure here. You're cutting lymph nodes, you're just leaving this behind, right? The second thing you have to do, or you have to remember, is that the stump that you leave should not be too long. Why? Because only short gastric supplying it. And suppose if I decide to leave this part of stump, now this blood supply is not enough to supply it. So I have to have an adequate stump which has got an adequate blood supply. So two things very important when you're doing a partial gastrectomy for gastric cancer. One, that the stump should be adequately supplied by the short gastric vessels. And number two, the stump should not be too long. See, it not be the stump is too long, it will not be able to get into the supply in short gastric. So maintaining vascularity in the gastric stump is not really going to happen. So remember, when you're doing a partial gastrectomy, gastric cancer, two things uppermost in your mind. Number one, don't loop too long, don't leave too long a stump of stomach behind. And number two, please do not damage the short gastric vessels. If you choose to do so, then you land up with a total gastrectomy. You cannot do a partial gastrectomy. So if you're doing a partial gastrectomy, you're doing a total gastrectomy. That means you have got one end which you have to anastomose somewhere. So either do a Roux-en-Y, general reconstruction, or a loop gastrogenostomy, or do a Billroth, or you do a gastrogenital. See, this is how you do the reconstruction. Very beautifully depicted out here. This is what Billroth one. You cut, you do a partial gastrectomy, and they do an anastomosis, they do them out. This patient fortunate enough that he had a partial gastrectomy only on the distal part. That's how you do it. Okay. Now here, what do? You don't do a Billroth 1. Now you do a Billroth 2 construction and or a Polya. Remember yesterday I told you Polya through the same incision and Billroth 2 through a separate incision. So here basically what you're doing, a 15 centimeter of the loop. So this is a loop. 15 centimeter of the loop is taken, either anticolic or retrocolic. Yesterday I told you that if you want to prevent dumping syndrome, it should be taken retrocolic, right behind them. But this is basically a figure which is showing anticolic. The transcolon is behind this anticolic. So preferably do a retrocolic. If not, then you can do an anticolic. 15 centimeter length of the loop. That means 15 and 15, 30 centimeters. But if you're taking a Roux-en-Y, which is the preferred method of doing a reconstruction, then it should be a 30 centimeter. This should be 30 centimeter. 30 centimeter basically means what? From where you do a jejunogenostomy up to the part, there's a drag down. So you cut basically, if this is a loop, you cut out here and you take the part here and the rest you anastomose out here. That's been done out here. This is the DJ junction and this is the 30 centimeter. So the three methods of reconstruction after partial gastrectomy. This partial gastrectomy reconstruction. Because in total gastrectomy you would have cut out here, you would have cut here. So there is no question of having anything like Billroth 1. Not possible in a total gastrectomy. So in a total gastrectomy, either you can do a Billroth 2 or a Roux-en-Y, because a loop can be taken out here and this can be taken out here. So if you're doing a total gastrectomy, number 2 and number 3 possible. You're doing a partial gastrectomy, 1, 2, and 3 all possible. Is that clear? Right, I've shown from where this picked up and you can easily pick it up. So this is a figure which is very well depicting what? This is basically a growth and I choose to do a partial gastrectomy. Now see, with this, I could have cut out here also. I could have done that. But by doing that and I've cleared the gastric, would this amount of stomach be sustained by only by short gastric? Probably not. That's why I have to cut here. A small segment. A segment good enough for creating an anastomosis. And this is how it's done. Roux-en-Y, gastrojejunal anastomosis, and this segment, 30 to 60 centimeter. And see the anastomosis such that the food which is coming out here is coming in a peristaltic fashion. So this is isoperistaltic. It's not retroperistaltic, isoperistaltic. And this is the jejunojejunal. Clear? So this is basically a figure which will make you understand what is the preferred method. Now I could have taken loop also here. But what happened with the loop? What happens with the loop? The bile content will go out here and part go up here and part then down. Part of it, because this is a jejunalostomy, no doubt, but some of it goes here. So this method of anastomosis or reconstruction would always give rise to some amount of biliary reflux, which we don't want. So the difference between a loop and a Roux-en-Y is that this would always have some amount of biliary reflux. This will never have any biliary reflux. And that is the main difference, because biliary reflux has its own problem. Total gastrectomy. The indications: proximal gastric cancers, distal gastric cancer with multiple lymph node mets. That means a D2 or D3 lymph node dissection. So even distal, suppose if I have the malignancy in the lower part, as I showed you out here. So a tumor in this part. But if there are a whole lot of lymph nodes out here, then what do? I do a total gastrectomy. So that's another indication of total gastrectomy. Also been advised a prophylactic treatment in a number of genetic cancers. So E. cadherin, G. mutations, so on and so forth. So the indications basically proximal. Number 2, distal, but with extended D2 or D3 dissection to be done, and laminitis plastica, and some genetic cancer. These are the clear indications of doing a total gastrectomy in a patient of gastric cancer. Right? What does it involve? It involves the entire stomach, the gastroesophageal junction, and the greater omentum. 3 things very important. And the restoration, I told you how you do it. Now, as I said, 4 to 6 centimeters in partial gastrectomy, 4 to 6 proximal, and 2 centimeters in distal. in partial gastrectomy. What is a total excision or R0 excision in TG? A total gastrectomy. That is basically when you have a normal esophageal mucosa and a normal duodenal mucosa. Until then, you don't stop, you have to excise everything. Is that clear? So in partial gastrectomy, 4 to 6 proximal, 2 distal. In the total gastrectomy, a normal esophageal mucosa and a normal duodenal mucosa are the limits of extension. And this is how it's done. So this is a proximal, I remove it, and then what do? I take a Roux-en-Y and I'm anastomosing it where? This is the esophagus, right? And then I'm doing it out here. Another method doing it is, this will give you some added length that you fold it upon itself and then you do anastomosis. Let's remember Roux-en-Y. This is basically for the postgraduates, how to do it. For those who are undergraduates in this lecture, basically there's an esophago-jejunal anastomosis done as a Roux-en-Y. So Roux-en-Y, esophago-jejunostomy. Clear? Along with the jejunal genostomy. Nothing very difficult about this figure, easy to understand. This was original tumor. I cut it from here, then I cut here, I took this loop upstairs, and this was then anastomosis. Is that clear? Okay. Now, terms associated with gastrectomy: R resection, we are referring to R0, microscopically margin negative. Do you have any R types? Yes, R1 is there. Microscopic margins. R2, gross residual disease. Doesn't make any sense. If you're doing a R2 kind of an excision, does it make sense? Absolutely not. Don't do it. Don't do it. So R2 residual, leaving a residual behind, it is just you're practicing something which is not a benefit for the patient. You're just trying to do something in a patient, just trying to make a fool of the patient and a fool of yourself. If you're doing an R2 resection, it is not worth it. Don't do it, please. R1, you can get away with it. I did macroscopically, I didn't find anything. But when histology was done, this patient had R1, so that is basically understandable. But R2 is not understandable, but it's still been mentioned, right? Then you come to the D resection. That's very important. What is the D resection? And every time now we're talking about D resection, if you talk about gastric cancer, we'll always talk about D1 and D2 resections. Whenever we talk about gastric cancers, in any conference, in any answer to a question in your test papers, anywhere, any explanation, it has to be either a D1 or D2, with the common ones, D3, D4 are not usually done. So basically, what are we looking at? Lymphatic dissection must be at a level higher than the highest echelon of metastatic lymph node. That means, suppose if the lymph node is involved out here, just the perigastric, then I have to go and clear this. If they're involved out here, then I have to go one stage further. So it should be a stage higher than the involved group of lymph nodes. That's one. Now, if it is, I'm doing a D1, what am I doing? If I'm saying I'm doing a D1 resection of the stomach, what am I doing? What I'm doing is I'm doing a partial or total gastrectomy as required in that patient. In addition, when I say D1 resection, what I'm doing, I'm removing lymph node stations 1 to 7. That means all the lymph nodes here and the left gastric lymph node. So when I'm saying D1 resection, I'm basically doing a excision of the stomach as required, partial or total. And in addition, what am I doing is I am removing all the lymph nodes from 1 to 7. Practically, is it done? Even not here, even the Western world. No, it's not done. Why? I'll tell you why. Because removing these lymph nodes, the cardiac lymph node, nobody does it. You don't go higher up, you don't remove 1 and 2. You don't do it, right? And number 7, you don't do it. So in all practicality, D1 resection, theoretically, yes, 1 to 7. But practically, what we're really doing is we're removing only 3 to 6 lymph nodes. That means lymph node from 3 to lymph node up to 6 group. So I'm removing everything from the lesser curvature, removing everything from the greater curvature. Agreed. I'm removing the suprapyloric and the infrapyloric. That means just 4, 3, 4, 5, and 6. That is practical. That's why I said in practice it is usually 3 to 6, but theoretically it should be 1 to 7 or at least 1 to 6. You may like to leave or you may afford to leave the 7 behind, but 1 to 6, that means all these should be removed. All lesser curvature, all greater curvature. You can't get away without doing that. All lesser curvature means 1, 2, 3, 4, 5, and 6 up to this part. So D1 excision is whatever type of gastrectomy you're doing, partial or total, whatever, and from 1 to 6 minimum or 7 included. But practically, you may be doing just 3 and 6. D1 plus is a new term which has come in, and that is again partial or total. Just forget it, that is gastric section, whatever required. We'll be repeating that every time. But here, basically, when you have this, you're doing an extended lymph node excision in the form of what? Along with SEM, I'm also in 7. I'm including what? 88B. What is that? Common hepatic. I'm including 9 and I'm including 11. See, what am I including? I'm including this whole thing, the axis, and I'm including what? The splenic. 11 is what? Splenic. So I'm removing the lymph nodes behind the stomach and removing the lymph nodes along the major vessels from where the vessels to the stomach come out, and I'm removing the perigastric. So that is basically an extended lymph node excision at the D1 plus, right? So Japanese surgeon, they do D1 plus even for CT1N0. C1N0, T1N0. Does it require that kind of resection? No, it doesn't. There's no lymph node. There's no diagnosable lymph node. So if you decided to do a surgery in CT1 and 0, T1 basically means what? Mucosa and submucosa. And N0 means what? No lymph node. So if you're doing surgery, you'll just remove, let's say I'm doing a distal gastrectomy, I'll removing 3, I'll removing 4, 5 and 6. That's all. But they do what? They would remove the lymph node number 7, 8 and 9 also. So that is the difference in Japanese surgeon and we Indian surgeons, or as we call it, the Western group, right? T2, which is now supposed to be the cornerstone of all kinds of excision, is D1 plus. That means the D1 plus we all talked about, that we have removed up to what? We have removed up to what? We have removed up to 8, 9 and 11. Okay. Now, when we do the D2, along with those, now we are extending it to 11, D and 12A. Meaning what? That I am removing the distal splenic, and 12 is what? This is 12. That means I'm clearing the whole of the lesser omentum and the free edge of lesser omentum of all lymph nodes. That means along with this, so I've removed all of this, I removed this, I removed all along the splenic, and I'm removing the lesser. But the Japanese D2, along with this, they will also remove the whole of the greater omentum and the lesser omentum, the whole lesser omentum. They'll do a splenectomy and they'll do a distal pancreatectomy. The Japanese D2 is different from the Western D2. In D2 of the West, what is included apart from these lymph nodes up to 12A, what is included is just omentectomy. Not also lesser. It is only what's known as bursectomy. Only greater omentum is removed. Only spleen not removed, distal pancreas not removed, and lesser omentum is known as bursectomy, not done. D3, you may like to remember, not like to remember, this is basically experimental. Here you go more further and try to remove 13, 14 up to 16, and D4 you go beyond 15, sorry, this up to 14, and here you go up to 15, 16. So just forget D3 and D4, just remember D1 and D2, which are very, very important. And what are the new guidelines? The new guidelines basically, for advanced proximal gastric cancer, see, advanced proximal gastric cancer, that is basically gastric cancer of the proximal, that means cardiac. And what do they say? The D category, we define the lymphatic dissection. T2 lymphadenectomy is the standard of care for all operable gastric cancer. Underline this. Underline this. That is the standard of care. That means in any operable gastric cancer, if you ask what kind of surgery you'd like to do, you'll say D2 type of gastric resection. D2 gastric resection. When you say D2 gastric resection, immediately means that you're doing whatever you have to do, either partial or gastrectomy, and along with that, you're removing up to what? Removing up to the celiac axis lymph nodes, meaning 7, 8, 9. That means 1 to 9 lymph nodes along with 11, the splenic, is being removed. That is D2 gastrectomy, right? So what about the spleen? If it is involving the upper third of the greater curvature, that means the stomach, upper third involved, then the splenic hilar lymph node, that means group 10, might be included as a standard component. But if the upper third of the greater curvature is not involved, don't go ahead and do a removal of the splenic hilar. These are guidelines. You'll find these guidelines anyway. So these are basically December 2018 guidelines and have to be adhered to. Prophylactic splenectomy, as the Japanese do, should be avoided. See, right? For advanced gastric cancer, does not invade the greater curvature, don't do a prophylactic splenectomy. Don't do it. It increases operative morbidity and it does not improve the survival. Without. So if it is not improve the survival, why go ahead and do an increased morbid procedure? Don't do it. Similarly, distal pancreatectomy should not be done. Right? So in Japan, it is completely splenectomy. Right? For all operable gastric cancer. They do D2 for every cancer. Minimum D2. They're also going for D3, D4. But minimum surgery for them is D2. Minimum surgery for us is D1 and then of course D2. D2 lymph node excision, cancer-specific mortality rates are significantly lower in patients who undergo D2 lymph node dissection rather than D1. Right? Cancer-specific mortality rates are significantly lower in those patients. That's a recent study. So let's see what it means. Basically, what we are saying is that before we go to that, let's say bursectomy. What is bursectomy? Bursectomy basically is removing the bursa. Which bursa are we talking about? The lesser sac. That basically means what? The whole of the lesser omentum and the peritoneum, which is lining the posterior layer of the lesser sac. That means not only am I removing that, I'm also removing the peritoneum, which is overlying the pancreas and overlying the whole of the bursa is being removed. You understand what the bursa is? Lesser sac, the whole lesser sac. That means the peritoneum overlying the pancreas, the posterior wall or the retroperitoneum, the lesser omentum, and the whole of the stomach is being bared, and only the stump is removed or the whole stomach is removed. That is bursectomy. They do it. Bursectomy is no longer advisable. The new guidelines suggest what? That bursectomy should be avoided as a standard component of D2 hysterectomy. Don't do it. They do it. Don't do it. And even the standard guidelines, even for them, they should also adhere to it. They say bursectomy is not required. They're not required. Because see, I said that the Japanese surgeon is doing what? He's removing the bursa. Lesser sac is what? Bursa, less omentum. Spleen and distal pancreatectomy. Not required. Right? Suggests that bursectomy should be avoided as a standard component D2. D3 you can do it. But as a component D2 should not be done. D2 dissection without greater omentum still not being advised because they don't have hard and fast evidence. So it is still being advised that greater omentum should be removed, even in D2. Laparoscopic and robotic D2 is now an acceptable method giving equally good results. So if you're asked about the operable gastric cancer, you would say either D1 or standard care would be D2 excision done laparoscopically, robotically, or by open method. The three answers are right? And that is why lab D2 is now the new alternative standard for a partial gastrectomy for resectable gastric cancer, not for total gastrectomy. So the partial gastrectomy, yes, you can go ahead and do it. A robotic probably may also do a total gastrectomy, but as a laparoscopic, it is only partial gastrectomy D2 which can be done. So I'm completely referring to D2. Immediately make that picture in your mind. Then you remember it. D2. What is D2? D2. Even the axis of the celiac lymph nodes have to be removed. The lymph nodes along the stomach and the celiac axis. D2 immediately you say, yes, I'm going to remove 7, 8, and 9. 7, 8, and 9. I'm going to remove it immediately. And then what? Splenic. That is 11. 7, 8, 9, 11. D1, 1 to 7 or 1 to 6. D2, 7, 8, 9, 11. Simple. Just note it down. Okay. So D2 gastrectomy 7, 8, 9, and 11 to be included along with D1, which removes D1 to D7. Okay. Now extended lymph node dissection D3, D4 for gastric cancer. See, what does it say? Investigational treatment option should only perform a specialized center. That's why I said even if you don't remember D3, D4, doesn't matter. Forget it. The Cochrane review, one review which we already adhere to, reviewing D1 versus D2. I didn't purposely touch on that D1, D2 in the last slide. I said we'll talk about later. Now, what does it say? They did a meta-analysis of 2,500 patients enrolled in 8 Asian and European lymphadenectomy, right? D1, D2, and D3. That was a trial. And they took the trial and they took the data from their 2,500 patients. And what did they find? They found D2 and D3, there was no difference in survival, even in the Asian lymph node excision. So that means if there is no difference in survival in D2 and D3, why do D3? Let's do D2. Very easy. Why going for more dissection? If my survival by doing a lesser operation is as same as yours, where you're doing a more dissection, causing more morbidity, so why should I do it? I'll do my dissection. I'm cutting less. So D2 should be preferred over D3 because no difference in survival, right? And if you look at the overall disease-free survival between D1 and D2, I find, what do I find? That D1 also gives equal to D2. So now the other person was doing D1, he's at a better space. He's at a better stage. He said, look, with D1, I'm getting what you're getting with D2 and what he's getting with D3 with minimum amount of dissection. So overall in disease-free survival in trials of D1 versus D2, D1 was giving equal results to D2 and D3. And that is why most of the current Western guidelines recommend at least a D1 lymphadenectomy with a total nodal yield of 15 or more. So what is the answer now? The answer to the primary operation for a gastric cancer patient operable, the answer is either I do a D1 lymphadenectomy or D1 gastric resection with at least 15 or more lymph nodes, or I do a standard D2. Is that clear? And that too should be a modified D2. Why? Because I'm not removing the pancreas and not removing the spleen, right? So the answer to curable excision of gastric cancer, curable, remember, of gastric cancer is either a D1 with 15 lymph nodes or a modified D2. Clear? That should be the answer. And don't forget it. You can write it down, you can underline it. Palliative, I'm not able to do a curative. What can I do? I'll just reread them to you because they again is a whole different topic, but just note down. I do a subtotal gastrectomy, non-oncological. That is not RO. It is not R0. It could be R1. So subtotal gastrectomy. I can do a gastric bypass. The growth is so much, can't do anything, but I just want to palliate this patient. He can eat something. I can take care of his gastric outflow obstruction. I just connect the jejunum to the stomach proximal part where there is no growth. And I have to do anterior. Now I'm going to not going into the details of anterior versus posterior, but just remember for a benign condition, posterior gastrogenostomy, for a malignancy of the stomach, anterior gastrogenostomy. Don't forget it, write it down, underline it. The reason being simple that an anterior gastrogenostomy would basically anterior gastroscopy benefits of carcinoma stomach. Why? Because the growth tends to permeate posteriorly. So if I'm doing a posterior gastrogenostomy in a patient of gastric cancer, that opening would be involved later on by a growth. So that has not served its purpose. It may serve its purpose for 15 days or 1 month. And then what do I find? I find the growth has gone into the gastrogenostomy site. So I would not do a posterior gastrogenostomy in a patient with gastric cancer. With a gastric cancer, I'll do an anterior gastrogenostomy. With a benign condition, I can hope to do both anterior and posterior. Is that clear? Exclusion bypass, that means I've got this stomach in front of me. I've got the stomach, the whole stomach in front of me. The growth is here. Exclusion basically means I cut it here. I leave this close end and I take this proximal end and I do anastomosis, right? See, suppose the growth is here. And what do I do in exclusion? I cut it here. I cut it here. The growth is segregated out here. This part does not have any growth as such. And I would just anastomose out here. Why do I want to do an exclusion? For the simple reason, by removing this, at least the growth is not going to cross this bridge. This is separate, this is separate now. It's not going to cross the bridge. But remember one thing, if you're doing an exclusion bypass, one thing is very important, that this part would be secreting something. The gastric juice is secreting, and they should come out here. If you find there's an obstruction here, the amount of secretion out here is what's going to do. Where is it going to go? Nowhere. It will break your anastomosis. It will break your closure. You just close it. The growth is here. The pent-up secretion will burst through. So exclusion bypass can only be done when you've ensured that the gastric outflow into the duodenum is still patent. Remember that. So when I say exclusion bypass, just write it down, exclusion bypass with a patent gastric outflow. That's important. You can, I put in a stent. The growth, there's a growth in the pylorus. I put in a metal stent, and that takes care temporarily. I can do a feeding tube placement for proximal growths. For a proximal growth, endoscopic placement, percutaneous gastrostomy, open gastrostomy. Basically, this should not be proximal. It should be basically the distal growths, right? So proximal growth. Agree. Why? Because the growth is lying out here. The distal part can still accommodate your food, so I can put in a feeding tube. But if I've got a distal growth, if I put something in the stomach, doesn't make sense. It's not going to go through into the duodenum. So then I have to do a jejunostomy, feeding jejunostomy, either done endoscopically or either done by an open. Post-surgery outcomes, I'll just enumerate them for you. We already got to ask. Post-TG mortality, total gastrectomy mortality, less than 2%. Post-TG morbidity is 40%. That's very high. Complications include the systemic complications, pulmonary embolism, pneumonia, myocardial infarction, deep vein thrombosis. Technically related issues, I've not done a good anastomosis, anastomosis leaks. Or I've done a very good anastomosis, I've tightened everything so much that I got a stricture on my hands, especially when you're doing an esophago jejunostomy. It's not found in gastrogenostomy, strictures are not found, but strictures are there in a esophago jejunostomy, right? Post-gastric complication, leak at the site of jejunostomy or at the site esophageal jejunostomy, we already mentioned that. Duodenal stump leak, because when I've done this, I have closed the duodenum. But the duodenal stump can always leak, leading to a paraduodenal collection or a frank duodenal blowout, giving rise to generalized peritoneum. The patient has to be reoperated. Or there could be secondary hemorrhage. See, I've mentioned, I've cut all the vessels. The whole of the gastric bed is now clear. The left gastric has been cut, the splenic has been cut, the right gastric has been cut, the cloacs have been cut. One of them starts bleeding. So secondary hemorrhage as a result of infection. And torrential bleeding can't be controlled. You have to open up the patient. If you're fortunate, very small bleed, you take care conservatively, the patient will respond. But if it does not, then you have to go in and do a complete re-exploration. Long-term local recurrence or metachronous metastasis, the liver, lung, and bone. I hope you know what metachronous met says basically. Metachronous, if you understand, you have taken care of the primary, and then about 1 month, 2 months, 5 years, 6 months, or whatever, the metastasis appear at that time. So precocious, synchronous, and metachronous. Precocious, no evidence of primary, liver mets or mets anyway. That is precocious mets. Synchronous, both the primary and secondary at the same time. Metachronous, primary taken care of. After a period of time, you find the mets. So these are three types of mets, not only for liver, but anything. Chemotherapy, I'll just mention it for you because I said that you can give it as a adjunctive or it can be induction. Both induction, especially which type? In the type where you have the advanced carcinoma, you give it as a pre-operative and then operative done as a second stage. And the best is the ECF regime in a 21-day cycle, and the drug just slow them down. You may not like to repeat the doses, especially for the PGs, they can mention the doses. But as far as the UG are concerned, epirubicin, which is anthracycline, cisplatinum, and 5-FU, three drugs. ECF, E, C, and F. C for cisplatin, E for epirubicin, and 5-FU taken together, right? Amifostatin is mentioned because that takes care of the nephrotoxicity of cisplatin. So that can be given as an added, but otherwise epirubicin, cisplatin, and 5-FU. Chemotherapy second line may include docetaxel and ocetaxel. These are basically antimitotic agents. They can be included as a second line drug therapy. Right? Herceptin or trastuzumab can be given in those patients who are HER2 positive gastric cancer, less than 20%, but survival is poor and the drug is very, very costly. So it doesn't really make sense using this at the present moment. Why? Because we can't give very good results. So up to now, it is just an experimental drug, not in regular clinical usage. Radiotherapy is basically only for painful bony mets. Why? You cannot irradiate the stomach bed. Why? You got the major structures out there. You got the vessels, you got the pancreas, you got the spleen out there, the liver out there. So the bed is never radiated. Radiotherapy is only used for bony mets of a gastric cancer. And that's a palliative treatment for bony mets, right? Prognosis, staging is far more important, predicting the survival rather than any classification. So government is only to help you with the prognostication. The MIG is not going to help you. Then basically just to decide what kind of malignancy it is. The staging helps you, and that also the end stage. The end stage is very important. The T4 probably has a lesser role, but end stage is of primary importance, right? Meningitis disease, I'll just touch upon it. I think we just got 5-10 minutes more. Gross mucosal hypertrophy, and I mentioned this because it's a pre-malignant condition, right? Overexpression transforming growth factor alpha, which binds to epithelial growth factor. You can just take it from the textbooks. Gastric lymphomas just mentioned because primary and secondary, two of them, primary gastric lymphomas, they are 5% of gastric malignancy, right? The secondary lymphoma is basically a metastasis from somewhere else that can easily be tackled when you're treating that particular lymphoma. It disappears. Now, mainly the primary involves the gastric antrum, and it has got something to do with Helicobacter. These are large B cell lymphomas, extranodal marginal cell lymphomas, mantle cell or follicular lymphoma. The mild lymphoma, the mucosal associated lymphoid disease, is classified extranodal marginal lymphomas, and these are lymphomas which respond to chemotherapy in totality. The symptoms are vague, and the generation at 6th and 7th decade, that is the time when you get these lymphomas, and the symptoms are vague symptoms, just like in early gastric cancer, nothing to differentiate based on the symptom. More common men, just like in gastric cancer, nothing different over there. Gastric lymphoma, role of resection gastroma remains controversial. So if you got a gastric lymphoma, trying to do a total gastrectomy or partial gastrectomy is questionable. What kind of role? So basically, the chemotherapy, the CHOP regimes help in a big way. Cyclophosphamide, hydroxydonomycin, oncoven, prednisone. The CHOP regime, just note down CHOP regime. That is one of the regimes which helps in these mild lymphomas. And recent evidence suggests that early stage mild lymphomas in some patients, the CHOP regime helps very much. Limited diffuse large B cell lymphoma and effectively treated by H. pylori eradication can be done in these groups. So remember one thing: treat the H. pylori, many of the lymphomas disappear. They simply disappear. If they don't, then go ahead and do a CHOP regime. And then the final is the GIST, the gastrointestinal stromal tumors. They are 60% of intestinal GIST are gastric, 60%. That is a major chunk of the GIST tumors that we have. Between 50-70 years, pathology we all know now, we know they arise from the cells of Kajal. And when you talk about anatomy, remember cells of Kajal are what? The pacemaker cells that you find in the muscular propria. The pacemaker cell, the gastric pacemaker, they were cells of Kajal. The duodenal pacemaker has cells of Kajal. Right? So these are autonomic nerve related GI pacemaker cells that regulate the intestinal motility. So what is the pacemaker doing? It is sending out those signals which are housekeeper signals. And then subsequently they are banished in favor of, as soon as they have some meal, they are banished in favor of the proper peristaltic activity. Now, what is characteristic about them? That they express the KIT gene, and this is basically transmembrane tyrosine kinase receptor. All of them would be having it, so they are KIT specific, and that's one of the methods in which you can distinguish the GIST from true smooth muscle neoplasm, which will not be expressing the KIT gene. And most of these GIST are CD34 positive, right? So two things to differentiate GIST from the smooth muscle tumors. Number one, KIT positive, and number two, CD34 positive. So every GIST is not malignant. Remember that. They could be benign GIST. It is malignant if mitotic index 5/50, more than 50 mitosis, size greater than 5 centimeter, cellular atypia, necrosis, local invasion, and c-KIT mutation. If you find any of these, it is a malignant GIST, right? Clinical manifestations: bleeding, pain, dyspepsia, abdominal discomfort, lump in abdomen, nausea, vomiting, loss of appetite, weight loss. So these are more or less the general symptoms found in any malignancy of the stomach. The treatment is surgery. Imatinib mesylate is a tyrosine kinase inhibitor approved for metastatic GIST, and it is used. Glivec is a drug used not uncommonly, I would say very commonly, not very uncommonly, it is used. And 5 is survival figures of 48, which is better than the gastric carcinoma. The gastric carcinoma figures are what? 30%. Here it is 48%. So it's probably a better tumor to have if you have a choice. Okay, so that finishes this lecture, and I think we will not be having any stomach part 4 because just leaves one or two benign condition. I think you can go and look it up if at all you want to, if you're interested in. So that finishes the stomach for you, and I would be happy to answer any questions if you have any, and if not, then any questions? Okay. Then that would be all. Thank you for your time, and thank you for staying back in such a long lecture of 2 hours. Goodbye.
Thank you, sir.
Thank you, sir.